Good afternoon, Dr. Enya.
Good afternoon, Doctor.
So, good afternoon to all. A warm welcome to our guest speaker for today's webinar, Dr. Enya E, and to each one of you to the 7th episode of Kayaprabodhini webinar series organized by the Department of Kayachikitsa, ITRA Jamnagar. I am Dr. Charvi Mehta, and it is my absolute privilege to have such esteemed professionals gathered here today, all sharing a common dedication to the holistic well-being of individuals through the lens of Ayurveda. As all of you know, today and every year, the 19th of April is celebrated as World Liver Day to spread awareness about the liver-related diseases. According to the report published by WHO, about 20 lakh people succumb to death due to diseases associated with liver. In India, liver-related ailments are one of the most common causes of the death. It is predicted that there will be a rise in the liver-related disease by 35% if there is no awareness for it. The theme for the Liver Day, World Liver Day 2024 is Keep Your Liver Healthy and Disease Free. One of the liver disease, that is fatty liver, is a very common liver disease that can affect the people of even young age group, and it is important to explore the knowledge related to liver disorders. Our guest speaker today, herself has also done her research work on the fatty liver NAFLD, and we have few more researchers in ITRA, like Dr. Nisha Rani in 2022 tested the efficacy of Prima Kajali and Pripatu Kajali tablets with lifestyle modification in the management of non-alcoholic fatty liver disease, and the results showed the significant effect of Prima Kajali. Another research work that is recently done in the last year 2023 with the effect of classical and Nitya variation followed by Vidangadic Sharyog in NAFLD also showed the promising results of Nitya variation and Vidangadic Sharyog in the management of NAFLD. Today, Dr. Enya E, who has thoroughly researched the liver diseases, will be sharing her knowledge on the topic decoding liver function test, exploring its clinical and diagnostic pathways. Before we commence, let me give you a brief introduction of our guest speaker today. Dr. Enya E is currently working as a research officer, and she has completed her BAMS from Government Ayurveda College, Kerala, and her PhD from IPGTN-RA, Gujarat Ayurveda University, Jamnagar. She has a work experience of assistant professor at the Kerala and research officer in the Ministry of Ayush since 2015. In her academic achievements, she had been awarded many a times as a first rank holder in BAMS in the PGDYN examination and many more. She has also been a recipient of Himalaya Jeevak Award, the Kotakal Aryaveda Shala Sanitary Award, and many more. She has been an author of more than 9 research publications and co-author of more than 6 research publications. She is also an author of a book for the selected research papers of safety and efficacy of Panchakarma, content developer of the e-book developed by NARIP, and also a author of the book chapter. Adding much more to her academic achievements, she is NABH Accreditation Coordinator, expert member of Ayush ICMR Advanced Center for Integrative Health Research Screening Cum Proposal Development Committee. She is also a designated reviewer for the Studentship Program for Ayurveda Research Camp, that is PARC. She has presented papers in various national and international conferences and delivered lectures in various CMEs and ROTCs, and she is executing various IMR, EMR, and collaborative projects as a PI, OPI, and nodal officer. She has attended training programs and workshops on research methodology, statistics, NABH norms organized by CCRAS, Ministry of Ayush, IIPS, and many more. So we are thankful to Madam to be here with us. And before we commence, I wish to extend our heartfelt appreciation to our Honorable Director, Professor Amit Thakur sir, and our esteemed HOD, Dr. Mandeep Goyal ma'am, for their consistent support and invaluable guidance throughout this webinar series. So, without further delay, let us embark on this journey of exploration and learning with enthusiasm and an open mind. Thank you for joining us. And before we start, we have some instructions for the participants that there is a pre-assessment form which is shared in the link in the comment box. So all the participants are instructed to fill up that link, And also, all the participants are instructed to remain logged in for at least 45 minutes, to be eligible for the certificate. And the queries, if any, will be answered by our expert speaker at the end of the webinar. So we take a few minutes so that the participants can join the pre-test link and complete it. And then I will request Dr. Remia ma'am to please start her expert talk. All the participants are instructed to quickly fill up the pre-assessment form, which is given in the chat box. You have 7 minutes to fill up that form.
Thank you, Dr. Chami, for your nice introduction. Am I audible?
Yes, ma'am. You are audible, ma'am.
Okay, thank you. So let's wait for a few minutes now.
Yes, ma'am. I think you can start, ma'am.
So a very good afternoon to one and all. Respected Director Sir, Professor and HOD of Department Mandeep ma'am, faculties and students of Department of Biology and dear friends. On this World Liver Day, I would like to share some thoughts regarding decoding of liver function test. So before starting, I would like to express my gratitude to my mentor, my guide, Mandeep ma'am, who has introduced me into the topic of liver disorders during my PhD days. Thank you, ma'am. Thank you for this opportunity. And without wasting much time, I'm going into the topic. Slides are moving, right?
Yes, ma'am. Slides are moving.
Okay. So before understanding into the liver function test, first we want to know where the liver is located, what the liver is doing. We know liver is the largest organ in our body. It is about 2% of body weight. It is situated in the right upper quadrant of abdomen. It is divided into two quadrants. That is evident from this picture, right lobe and left lobe. Gallbladder is situated on the inferior surface. Liver is supplied by systemic circulation and portal circulation. Liver secrete bile into hepatic duct. This hepatic duct and cystic duct from gallbladder forms the common bile duct. Along with pancreatic duct, this opens into duodenum, second part of duodenum, that is ampulla, through ampulla of water. So the bile secreted by the liver reaches into the duodenum through the common bile duct. Then liver is the organ which is having a versatile functions in our body. It is having anabolic function, catabolic function, metabolic function, excretory, secretory, storage, immunological, a vast number of functions. It has important role in the metabolism of carbohydrate, protein, and cholesterol. It is necessary for the synthesis of many proteins, immunoglobulins, clotting factors, cholesterol, triglyceride. It is the storehouse of fat-soluble vitamins, many nutrients, micronutrients. As it is producing this clotting factors, it has important role in the coagulation, blood coagulation. It has important role in the immunological function also. So in this presentation, I would like to share the things under these headings: LFT, enzymatic assay, urine analysis, proteins, coagulation studies, copper and iron profile, and so on. So first we can discuss about liver function test. Liver function test, as the name implies, it indicates the function of liver. All these contents mentioned here, bilirubin, transaminases, ALP, GGD, all these things are present in the hepatocytes. When the hepatocytes get damaged, they are released into the circulation. So when there is any injury or any disease in the liver, all these enzymes may get increased. But only with the increase of these enzymes, we cannot reach into the conclusion or reach into the final diagnosis. And any one of this panel could not be confirmatory for a liver diagnosis. And in many liver conditions, these enzymes may be normal also. So first one is bilirubin. Bilirubin, do you know from where it is being produced? You can write in the chat box. Actually, bilirubin is produced from the senescentated RBC. So from the RBC, bilirubin is being produced. This bilirubin is entered into the blood circulation. Through the blood, it reaches to the liver.
Dr. Remia,
the minute. Conjugation. Yes, ma'am.
Can you put your slides on the presentation mode?
Okay, ma'am.
Yes.
Is it okay now?
Yes, yes. Now you can continue.
Okay. So when it reaches the liver, from there, conjugation of the bilirubin happens. And from there, it is secreted into the bile. Through the bile, it reaches the intestine. That is the pathway of the bilirubin. So when it is produced from the RBC, and up to the time when the conjugation takes place in the liver, the bilirubin is unconjugated. From the liver, it gets conjugated. So there is two types of conditions in which bilirubin is increased. One is unconjugated hyperbilirubinemia, and the other is conjugated hyperbilirubinemia. Sorry. So in unconjugated hyperbilirubinemia, what may be the reasons? There may be increased production of RBC. There may be increased destruction of RBC that we call hemolysis. Hemolysis may be seen in many different types of hemoglobinopathies, or maybe drug-induced hemolysis. In some people, this NSAIDs may induce hemolysis. The anti-Parkinsonian drugs, methyl-dopa, levodopa, all may induce hemolysis. That is one cause of unconjugated hyperbilirubinemia. The second one is decreased uptake of bilirubin into liver. It gets conjugated only if it reaches the liver. But if liver is not uptaking bilirubin, then conjugation doesn't happen. Then it is unconjugated. That happens in Gilbert's disease. The another one is decreased conjugation of bilirubin in the liver. In liver, this conjugation is being done with the help of glucuronide transferase enzyme. So if any deficiency of this enzyme, this conjugation will not happen. That happens in another inherited disorder, Crigler-Najjar syndrome. We know in preterm babies, many of them will have neonatal jaundice. The reason is actually this enzyme, glucuronide transferase, develops in the body only just few days prior to birth. But in preterm babies, these enzymes will not get produced. So it may take some time for them to convert this unconjugated bilirubin to conjugated bilirubin. That's why in majority of the preterm babies, we can see this neonatal jaundice. And in this conjugated hyperbilirubinemia, that is because of hepatic or post-hepatic reasons. Unconjugated because of pre-hepatic reason, conjugated because of hepatic or post-hepatic reason. Hepatic reason means any cause which may result in hepatocellular damage. Hepatitis due to virus, non-viral causes, drug-induced hepatitis, due to poisons, due to alcohol, due to fatty liver, or any chronic damages, chronic liver damages, or any infiltrative disorders. And in majority of the obstructive cases, obstruction of the hepatobiliary tree due to stones or pancreas, in that case also, this conjugated bilirubin will be more. And we can diagnose as jaundice only if the bilirubin is greater than 2.5. And in pure prehepatic condition, that is in hemolytic conditions, it will not be above 5 milligram per deciliter. So if bilirubin is less than 5, it is a clue for suspecting prehepatic disease or hemolytic anemias. And there is specific levels are mentioned for different types of liver disease for bilirubin. For example, in hepatocellular jaundice, it will be less than 10. In neoplastic cases, it will be less than 20. And or in extrahepatic cases, it will be more than 20 or 30 or 40. And it will be increased in acute hepatitis, chronic hepatitis. And if bilirubin is on the thing only increased in the NFT and all other things are normal, then it may not be due to hepatocellular disease. It may be because of hemolytic diseases, or it may be because of constitutional hyperbilirubinemia, like we have previously discussed Gilbert syndrome, Crigler-Najjar syndrome, etc. So I think that the bilirubin part is clear. Next, we are going to discuss about this aminotransferases, AST and ALT. Previously, they were called SGOT and SGPT. They are markers of hepatocellular injury. They are markers of hepatocellular injury. Actually, their increase will happen approximately 1 week before the increase of serum bilirubin. Okay. And regarding their origin, this AST is confined to heart, liver, skeletal muscle, and kidney. ALT to liver and kidney. So, in a condition, if only AST is elevated, it may be because of reasons other than pathologies other than liver diseases. For example, in congestive heart failure, in arrhythmias, diseases of trauma to skeletal muscles, in such conditions, AST will be high. But ALT will be high in conditions pertaining to liver diseases only. Their normal value in the adult is almost similar, about 10 to 40 units per liter. So generally in almost all liver conditions, AST and ALT will be raised. In fatty liver, in alcoholic hepatitis, in mild hepatitis, in almost all conditions, both AST and ALT will be raised. Along with the AST and ALT, we have to check for other parameters. Then only we can confirm whether it is because of hepatocellular injury or it is because of obstructive reasons. For example, if AST and ALT is less than 500 or AST and ALT is high, but alkaline phosphatase is not that much high, it is less than 3 times of its normal, then there will be hepatocellular injury. But if ALP is more than 3 times higher, then it will be because of obstructive jaundice. That points you will get more clear while we are discussing alkaline phosphatase. And we can use AST and ALT are the measures of recovery because in hepatic cases, the level of AST and ALT will increase. But in subsequent visits, if AST and ALT gets decreased, it means that good prognosis. But it's one condition called acute fulminant hepatitis, sudden and severe hepatitis. In that case, this AST goes beyond 4,000 or 5,000. In such cases, if AST or ALT declines very fastly, it doesn't mean that the condition is improving. That means the condition is worsening because hepatocytes are not in a state to produce enough enzymes. Okay, so generally, the decrease of AST and ALT will be considered as a sign of recovery, but it is not so in the case of acute fulminant hepatitis. This we have already discussed. In alcoholic hepatitis, AST will be high. In viral and chronic hepatitis, ALT will be high. And other points we discussed in heart-related issues, in skeletal muscles-related issues, AST will be higher. Don't confuse. The one thing is AST, which we have considered as SGOT prior. The second one is ALT or SGPT. So the next one is ALP, alkaline phosphatase. Alkaline phosphatase is suggestive of hepatobiliary pathology, mainly obstructive pathology. That is a group of enzymes. Its origin is from liver, bone, intestine, placenta, and other tumor-associated tissues. If ALP is elevated, we have to mainly suspect two types of disease. One is bone, other is liver. If ALP is elevated, we have to suspect two types of disease. One is bone and other is liver. Then how can we confirm? For that purpose, we have to go into further test. So ALP is increased in bone diseases. Any disease which increase calcium deposition into bone, like hyperthyroidism, hyperparathyroidism, obstructive liver conditions we have already discussed. In children, it will be high. In third trimester of pregnancy, it will be high. It will be high in patients who are taking anti-epileptics, antihistamines. If ALP only is elevated, it is bone disease. If along with the ALP, we are checking 5 nucleotidase and GGT that we will discuss in the coming slides. If they are also elevated with ALP, we can consider it as biliary disease. So if only ALP is elevated, that is bone disease. ALP will be very high in Paget's disease and metastatic bone disease. So these are the liver diseases having increased ALP. In almost all liver diseases, like other transaminases, ALP will also be increased. But it will be very much increased in biliary obstructions, obstructive diseases. We can see 10 times increase in CA of head of pancreases, 15 to 20 times increase in primary biliary cirrhosis, primary or metastatic carcinoma. So gamma glutamyl transferase is more sensitive than ALP in obstructive disease. And this is also a screening test for alcoholism. In alcoholism also, all enzymes will be elevated, but GGT is more specific to alcoholism. In alcoholism, GGT to ALP ratio will be more than 2.5. And if both ALP and GGT is raised, we can confirm that that is because of liver diseases. But only if ALP is raised, it is because of bone disease. So the same thing with the 5-NT, 5-ribonucleotide phosphohydrolase, 5-NT. This is also similar to ALP and GGT. The thing is that this is more confirmatory of obstructive pathology. This does not change with the drugs. This does not change with other sources. So this is very important for determining cholestatic liver disease. It will be increased in intrahepatic or extrahepatic obstructions. So that is about 5-NT. The next one is amylase. You know amylase enzyme for the digestion of carbohydrates. It is mainly produced by pancreas. Small amount is also being produced by liver, small intestine, and ovary. and it will be increased in biliary tract disease, common bile duct obstruction. It is also a sign of obstructive jaundice, and it is decreased in severe liver damage because there will be reduced production. So I hope that these points are clear for you. Bilirubin, conjugate and unconjugated bilirubin. Unconjugated hyperbilirubinemia is suggestive of prehepatic disease. Conjugated hyperbilirubinemia is suggestive of acute hepatocellular damage and obstructive disease. Then aminotransferases, AST and ALT. This AST is only confined to liver. AST is confined to heart and skeletal muscles also. If AST and ALT is higher than ALP, then it is hepatocellular injury. But if ALP is also high, then we have to think about obstructive jaundice. In case of obstructive jaundice, other than this AST and ALT, we will get higher levels of GGT, that is gamma glutamyl transferase, and 5-MT. Okay, so while coming to the jaundice, we have said that there will be hemolytic or prehepatic, hepatic, and obstructive. This may be the history of jaundice, the points we have to take care of while taking the history of a jaundice patient. In case of hemolytic jaundice, we have to check whether the patient's family is running this disease, or some races are showing more predisposition to certain hemoglobinopathies like sickle cell disease, thalassemia, or if they are taking any specific drugs, or they are having any signs of anemia. These points should be checked while we are assessing, we are taking the history of hemolytic jaundice. In case of hepatic jaundice, we have to check whether there is any flu-like symptoms, any previous history of jaundice, contact with any jaundice patient, or intake of alcohol, intake of any drugs. And in obstructive jaundice, usually the patient's presence with there is obstruction, no? Abdominal pain, dark urine, pale stools, and itching. Then how we can see the LFT and urine analysis in jaundice? So in hemolytic case, we know there is unconjugated hyperbilirubinemia. AST, ALT, and ALP may be normal, and bilirubin will not be there in urine because here unconjugated bilirubin is high. This unconjugated bilirubin is not water soluble, so it will not be present in urine. And like urobilinogen, this urobilinogen will be actually produced in intestine. Urobilinogen is producing intestine. It reaches the liver and then it is excreted into the bile. It again reaches liver. So if there is any hepatocellular pathology, then only urobilinogen will be increased in urine. Otherwise, it will not be there in urine. And in hepatocellular and obstructive jaundice, this conjugated bilirubin will be high. AST and ALT will be high, but in obstructive jaundice, alkaline phosphatase will be more higher. And in both cases, bilirubin will be present in urine. Urobilinogen will also be present in urine. But in complete obstructive jaundice, urobilinogen will be present in urine because there is complete obstruction. So bile is not going into the intestine. So urobilinogen is not formed in case of obstructive jaundice. So in obstructive jaundice also, complete obstructive jaundice also, there will be no urobilinogen in the urine. Although we got this blood and urine parameters, in jaundice patients, we should conduct ultrasonography because we may suspect it as hemolytic or hepatocellular, but sometimes there may be any obstructive pathology that may not be evident in the liver tissues. So to see the proper structure of the liver, biliary tree, portal and hepatic veins and spleen, ultrasound should be conducted. And there is another technique, ERCP, endoscopic retrograde cholangiopancreatography. That is endoscopy. And if it is not successful, PTC, percutaneous transhepatic cholangiography. All these are for viewing the structure of the biliary duct, common biliary duct and other parts of biliary tree. And liver biopsy is a gold standard of almost all liver disease. But we could not perform it in all patients because there is many risk like pain, bleeding, or sometimes it may stimulate the development of malignant tissue. Or for those people who are taking anticoagulant therapy, this liver biopsy should not be advised because there is more chance for bleeding. So otherwise, this liver biopsy can confirm the presence of hepatocellular damage than anything. So this is a portion of liver biopsy in normal liver biopsy and in fatty liver. In fatty liver also, liver biopsy is the gold standard, but we are not performing it in the early stages. Next, we can go to the assay of hepatitis. There are many causes for hepatitis. There are viral causes, non-viral causes, toxic causes. So acute fatty liver of pregnancy, all these are causes of hepatitis. So viruses means rubella virus may cause hepatitis, herpes simplex, chickenpox virus may cause hepatitis, cytomegalovirus may cause hepatitis. But the most common viruses are hepatitis A, B, C, D, E. Okay. So hepatitis A and B, the patients may be symptomatic or may be asymptomatic. There are many hepatitis B carriers which are asymptomatic. And this hepatitis A is mainly spread through poor hygienic places, or it spreads through the fecal-oral route. So where there is poor sanitation facilities, this hepatitis A easily spreads. They present with the normal features of jaundice, fever, malaise, anorexia, jaundice, right upper quadrant pain. The same features can be seen in hepatitis B also. Along with that, there will be arthralgia and rashes. Hepatitis B is being spread through blood transmission, sexual relationships. It can be transmitted through the placenta. If mother is hepatitis B positive, then the fetus may also get positive. And this hepatitis B is very common in homosexuals. For those who are who has undergone this tattooing, very easy chance for spreading through needles. So how can we diagnose this? We can diagnose this anti-immunoglobulins, anti-hepatitis virus A and anti-hepatitis virus B. We can detect the presence of this hepatitis viruses. We know if HBsAg, when we are checking HBsAg, if the patient is presenting with the symptoms of hepatitis, and in our treatment settings, we are prescribing HBsAg if we are doing, if we are going to prescribe any Anushastra procedures for the patient, if we are going to prescribe any Vasti kind of procedures like patient, or if the patient wants to go abroad, in such conditions, we are prescribing HBsAg. So if HBsAg is positive, it means that infection is present. Patient may be symptomatic or asymptomatic, but HBsAg positive means the infection is present. So if there is anti-HBC, then it means that presently or previously, the patient has been infected by hepatitis B virus. Then hepatitis C, its transmission is almost similar to hepatitis B. Its presence can be detected with the ELISA test, and its viral load can be understood with the RNA-PC test. Both this B and C may cause cirrhosis and hepatocellular carcinoma. And one more thing, this hepatitis D infection always occurs in patients with hepatitis B. And those who are having both these infections together, that will be poor prognosis. Hepatitis E is comparatively weaker, milder clinical course, recover earlier, but it is harmful for pregnant ladies. And this presence can also be identified by antibodies for hepatitis E virus. So these are some other causes of hepatitis. One is infectious mononucleosis, that is also a viral hepatitis. Yellow fever, that is also a viral hepatitis. And among the non-viral infection, leptospira is very important. Leptospira cause acute hepatitis. Actually, it is having two phases. The first phase is with the myalgia, fever, conjunctivitis, meningism. Sometimes the disease may get resolved, but sometimes the patient presents the features of jaundice and occasionally renal failure occurs. So this leptospirosis mainly seen in farmers and those who walk through soil because when the body gets in contact with the infected animal's urine. That is the reason for the spread of leptospirosis. It can be identified by ELISA and can be urine analysis, urine PCR also. It helps to identify the presence of the organism. And the confirmatory test is macro antibodies agglutination test for leptospira. And we know hepatic damage is also being caused by drugs. We always blame for paracetamols or non-steroid anti-inflammatory drugs or oral contraceptive pills for hepatic damage. But we know certain articles have been published regarding the role of Ayurvedic medicine in creating liver disease. Actually, it is our responsibility to protect or to defend against the baseless allegations against our medicines. But we are more responsible to patients. When such allegations arise, we have to think into the deep that whether there is any connection with our medicines and cause for liver diseases, because it may not be because of the problem of our medicines. The herbs may be cultivated near the areas of factories or highly polluted areas. The colored drugs may be kept near the roadsides before manufacturing the preparations. We are not sure whether they are properly getting washed or not. In such conditions, this will be highly loaded with metals and minerals, and there is chance for liver poisoning. Actually, my colleague has shared his experience to me. One RA patient has came to him for treatment. Initially, his LFT and everything was normal. He was undergone the treatment and got some kind of relief for this joint complaints. But after 2 months, because of this gastric complaints, LFT was checked. Previously, everything was normal, but after 2 months, this AST and ALT rise to 800. So he sent them for imaging and other techniques. Almost everything was normal, no obstructive pathologies or anything like that. But we could not find out for what reason this transaminases has been elevated. Whether it is because of the patient's pre-existing comorbidity or whether it is because of the medicines we have given to the patient. So at any time when such allegations occur, we have to defend, but at the same time, we have to check the genuinity of the cases also. So the next one is total protein. So the protein assesses the synthetic function of the liver. Liver synthesized protein, total protein, albumin, BUN, blood urea nitrogen, ammonia, all these are synthesized by liver. So in any conditions affecting the normal functioning of the liver, these proteins will be decreased. So all these proteins are having similar causes for increase and decrease. So they are mainly, these proteins are synthesized by liver and excreted by kidney. So they are mainly suggestive of liver and kidney disease and also nutritional deficiencies. So for protein, the normal range in adult is 5.5 to 7.5. All the proteins, protein, albumin, blood urea, nitrogen, increased in hypovolemic state, decreased in nutritional deficiency, decreased protein synthesis. Decreased protein synthesis means protein synthesis occurs in liver. So there is some issue with the liver. Increased loss of protein. So problem with the kidneys. Increased catabolism. In third trimester of pregnancy, malignancy, chronic disease, in all these conditions, proteins will be decreased. Similar with the albumin and similar with the blood urea nitrogen. But one thing is that in acute liver damage, we could not check for albumin because The half-life of albumin is about 20 days. So the acute liver injury cannot be understood by decreased albumin. After some days, after 3 weeks or 1 month, or after 2 months, when the edema develops, then we check for albumin and we can find out that it's hypoalbuminemia. And similar thing with blood urea nitrogen. In blood urea nitrogen also, it is decreased in overhydration, liver damaged, low protein diet. So when BUN is less than 6, it is a liver disease. If BUN is greater than 50, it is indicative of renal dysfunction. It is said that if there is severe renal impairment, BUN will be more than 50 to 150. If there is glomerular dysfunction, it will be again more. It will be more than 150 to 250. So the next about ammonia. This is also derived by protein degradation. But the ammonia is mainly helps to diagnose the cause of encephalopathy. There will be many causes of encephalopathy. So if we can get the presence of ammonia in excessive quantity, we say it because of hepatoencephalopathy. In the all advanced stages of liver diseases, the ammonia will be high. We have already discussed that liver is synthesizing almost the clotting factors. So all the clotting factors deficient in liver diseases, and prothrombin test and international normalized ratio. So this prothrombin time is the time for the clotting of the blood after adding thromboplastin, clotting of the plasma after adding thromboplastin. So this prothrombin time will be prolonged liver disease because there will be deficiency clotting factors and other thrombin, fibrinogen, etc. So prothrombin time will be prolonged and INR will also be increased in case of liver disease. Next, we can go through the profiles of some micronutrients. This one is copper. Generally, when will we check copper in a patient? If a patient in the age group of 10 to 25 or 15 to 25 presents with the features of liver diseases and neuropsychiatric diseases, tremor, hallucination, or confusion, then first we can check his or her eyes. There is one particular thing called Kaiser-Fleischer ring. It suggests that there is increased deposition of copper or increased copper in the serum. That is Wilson's disease. So in Wilson's disease, generally affect patients in the age group of 10 to 25. They show the presence with the neuropsychiatric or neuro extrapyramidal features, and their eyes show KF rings. In such patients, we can see that their serum copper levels will be high. And urinary copper excretion, if we are collecting the 24-hour urine and conduct the copper estimation, then the copper level will be high. But the ceruloplasmin level will be low. Ceruloplasmin is the copper carrying protein. Ceruloplasmin level will be low. That is the diagnostic criteria for Wilson's disease. And this copper will be increased in some other conditions also. It is an acute phase reactant. Acute phase reactant means all the acute phase reactants will increase in conditions of any infection, inflammation, tissue injury. So the copper will increase in any infection or inflammation or tissue injury. So only with the increase of serum copper, we cannot confirm the diagnosis as Wilson disease. For that, the ceruloplasmin will also be less. The normal range of ceruloplasmin is 22 to 58. When it comes less than 20 milligram per deciliter, there is chance for Wilson's disease. The next one is iron. Actually, iron itself is not having an individual existence in our body. It is being existed either as hemoglobin or myoglobin or with other enzymes. So iron profile includes the assessment of iron, ferritin, transferrin, TIBC. TIBC means total iron binding capacity. So this iron is obviously reduced in iron deficiency anemias, cancers, post-operative state. Iron will be reduced during menstruation, but it will be increased prior to menstruation. And it is increased in acute liver damages also. Acute liver damages, sometimes if the damage is at the higher level, this iron may cross more than 1000 microgram per deciliter. Ferritin, like iron, ferritin will be reduced in iron deficiency, but it will be increased in acute and chronic liver disease, alcoholism, malignancy, infection, inflammation, hyperthyroidism, etc. And total iron binding capacity. Iron binding capacity is also increased in acute liver damage. So in acute liver damage, this all the 4 profiles. In acute liver damage, this iron, ferritin, TIBC, everything will be increased. So next thing is cholesterol. Cholesterol metabolism is being taken place in liver. So we know cholesterol is increased in many lifestyle diseases, in BP, in hypertension, in diabetes, in obesity, or due to some fault lifestyles, smoking, alcohol. It is also increased in hepatocellular diseases. This cholesterol is transported from the blood to liver by HDL, and from liver to blood by LDL. So this HDL and LDL is also produced by liver. This HDL is known as high cholesterol. This HDL will be decreased in hepatocellular disease. LDL will be increased in hepatocellular disease. Both are produced by liver, but in hepatocellular disease, HDL will be produced less. But LDL will be produced more. The same thing with the triglycerides. Triglycerides will also increase in chronic liver disease and renal disease. It will be decreased in malnutrition and malabsorption. And in some people, only isolated triglyceridemia can be seen. Only the triglycerides may be elevated. That may be sometimes runs in families. They are familial hypertriglyceridemia. Or otherwise, if triglyceride is between 250 to 500, there may be chance of peripheral vascular disease. So that should be ruled out. If it is more than 500, pancreatitis may coexist. It is more than 500. And it may increase more than 5000 milligram per deciliter also in case of liver diseases. So the major 2 diseases that affecting the liver is primary biliary cirrhosis and sclerosing cholangitis. Primary sclerosing cholangitis. In both the conditions, some autoimmune antibodies are positive. This anti-mitochondrial antibody is positive for primary biliary cirrhosis. And anti-smooth muscle antibody is positive in primary sclerosing cholangitis. Both are obstructive type of liver pathologies. Along with this AMA and ASMA test, we can do other LFTs, we can do imaging techniques, color Dopplers, CT and other things for confirming the diagnosis of primary biliary cirrhosis and sclerosing cholangitis. So I think that we are running short of time. Anyway, I will try to complete within 10 minutes. So in chronic liver damage, we can see cirrhosis. Cirrhosis may be caused by many cases because of alcoholic liver disease, infections, genetic disease. In all chronic liver damages, the transaminases will be elevated. There will be leukocytosis, WBC will be elevated. There will be changes in the histology. There will be changes in the coagulation planet. The prothrombin time will be increased. And these are some genetically inherited chronic liver diseases. Hemochromatosis, Wilson's disease we have already discussed. Primary biliary cirrhosis, mainly in middle-aged females. We have discussed that it is an obstructive type of pathology. Liver biopsy can be done. The same with the sclerosing cholangitis. there are some infiltrative diseases and tumors, primary and secondary tumors. In primary hepatocellular carcinoma, this AFP will be rise, alpha fetoproteins, that cancer markers we will discuss. This cancer markers, in this presentations, I have included 3 cancer markers, AFP, CA125 and CEA. This AFP or alpha fetoprotein, the thing is that all these are not confirmatory test for hepatocellular carcinoma. They can present in the advanced stage of any liver disease. But the thing is that, but by the assessment of these cancer markers, we can assess either the progress of the disease or the recovery from the disease. Because in the subsequent visit, the quantity of alpha fetoprotein or CEA increases, it means that the condition is worsened. Or if they are getting reduced, it means that the therapy is effective. So this alpha fetoprotein, as the name, it is produced during the gestation by fetal liver and yolk sac. It is positive in hepatocellular carcinoma and carcinoma of testes and ovaries. But as I have said, as with its values, we could not predict the size, stage, and prognosis of the liver cancer. The next one is CA125. This is also increase in malignant disease. But we could not use this for the detection of cancer. But sequential determinations are useful to find out the progressive rates. The next one is carcinoembryonic antigen. That is also formed during the early fetal life. Sensitivity is increased with the advancing tumor stage. It is already will be increased in smokers. It is increased in liver diseases like alcoholism, cirrhosis, chronic active hepatitis, and obstructive jaundice. The next one is hepatomegaly. In USG, normally in our body, it is 16 centimeter. So it may raise up to 18, 20, 22. Hepatomegaly may occur because of many reasons, because of fat accumulation, because of vascular causes, maybe because of infections. Okay, so in acute hepatitis or due to vascular causes, it will be tender. On palpation, the patient will feel pain. But in case of infiltrative conditions, nodular conditions, it will be non-tender. For hepatomegaly, we can conduct all this liver function test. We can go for tumor markers. Before that, we can go for imaging techniques, ultrasound, CT, MRI. If needed, we can go for tumor markers or hepatitis viral markers. Or if there is nodular appearance, we can go for the check for Wilson's disease. And if needed, we can do biopsy also. This is fibroscan. This is to technique to determine the liver stiffness. Its merit is it is non-invasive, painless, and quick. The normal liver scarring measurement will be less than 7. When it is greater than 7, it means that the fatty accumulation starts. And when the patients develop cirrhosis, it will be 12 kilopascal. So the normal range will be less than 7. It is a non-invasive technique. When fat accumulation starts in first stages of non-alcoholic fatty liver and non-alcoholic steatohepatitis NASH, it will be between 7 to 10. And then with fibrosis, it will be more than 10. When cirrhosis happens, this liver scarring measurement will be greater than 12. This is the scoring of fibroscan. So we can come to the Ayurvedic spectrum. We can finish it within 5 minutes. So we have discussed prehepatic, hepatic, post-hepatic. So prehepatic can be correlated with or compared with the Pandu, hepatic and post-hepatic with the Kamala. Hepatic disease shows more resemblance with the Koshtagada Kamala and post-hepatic with the Shagagada Kamala. The Pandu Chigilsa is Sneha Prayam Pavanaje, Tikta Shidam tu Paitige, Shlaishmige Kadu Rupshoshnam. So Madhura, Snigda Chigilsa in Vadigam, Tikta Shida Chigilsa in Paitika Pandu, Kadu Rupshoshna Chigilsa in Kapaja Pandu. The same principle can be followed in the treatment of Kamala also. But in case of Shagagada Kamala, In Shagagada Kamala, there is Alpa Pitta because there is obstruction by anything, any Kapha predominant, obstruction to the Pitta due to Kapha predominance. So first we have to give Pitta Vardhana Chikitsa. Prashamla, Kadu Tikshnoksha Lavana. After that, if Pitta comes to Koshta, then we can go for Koshtagada Kamala Chikitsa. The basic treatment principle should be Deepanam, Pajanam, Pitta Shamanam. Tikta Kashaya Madhura Rasas are prescribed for Pitta Shamanam. So first Tikta Rasa should be given, then later Madhura Rasam. Srodho Shodhanam. Virejana is the most suitable Shodhana karma for liver disease, and Ruksha Virejana is more better. Yagrit Vishesha Rasayana Aushadas can be given, like Pippali, but while giving Pippali in Pitta predominant conditions like esophageal varices, portal hypertension, etc., it is better to avoid Pippali and other Ushnavirya drugs. And if complications develop, we can adopt the treatment of Shokam, Udaram, and Rekta Pitta. These are some drugs we can use for the Shamana and Shodhana of Shamana and Shodhana Chikitsa of Rektavaha Srodhavyadis like Pandu and Kamala. And I want to add just one point. Generally, we are considering Kamala and Pandu as Pitta Rekta Vigara. But Charaga mentioned Pandu in the treatment of, in the Lakshana of Rasavaha Srodhasa. So what are the causes of Rasavaha Srodhadushti? Guru Shida, Adisnigda, Adimatram Samashnadam, Rasavahini Dushyanti, Chintyanam Chadi Chintana. So along with the lifestyle modification, with the proper food at proper time and exercise, we have to think about stress-free life also. That is also essential to avoid this spectrum of diseases. Not only this spectrum of diseases, but almost all kinds of diseases. So we have to modify our lifestyle according to that. We have to practice suitable yogasanas and pranayama for that. Okay, then thank you all once again. Thank you, dear Mandit ma'am, and to all of you for your patient hearing. And there is the link for posters will also be shared. You can answer them. And after that, the answer key will be shared with you. Thank you.
Thank you, Dimya Madam, for an elaborative explanation of the different liver function tests and their clinical implications in different liver disorders, and also the Ayurveda way of understanding. We thank you very much for accepting our invitation and being over here. And as Madam has informed, the post-test link is also shared in the chat box. So I request all the participants to please fill up the post-test link. And parallelly, I also invite the queries, if any. All the participants, if any of the participants who have queries can write down their queries in the chat box, and Madam will answer the queries. It was a very nice and elaborative understanding of the different liver function tests, as all of us always go through the reports of all the different patients, and the clinical implication, if it is not kept in mind, then we cannot come to the perfect diagnosis. So it was a very nice and presentable slide with a thorough understanding. Thank you, ma'am.
Thank you. Can I leave?
Okay, ma'am. So I think there are no queries. So once again, thank you, ma'am, for being over here. And at the end of the webinar, I thank our director, sir, Professor Anup Thakur, sir, and our HOD, madam, Dr. Mandeep Goel, madam, for guiding us for this webinar series. I thank all the participants for taking part, involving in our webinar series. And we'll be back soon with a new topic in the next month with another Ayurveda expert. Thank you all for being over here. Thank you, one and all.
One more thing, I have shared my mail ID in the chat box. You can mail your queries if needed.
Yes.
Thank you.
Thank you. The participants can note down the mail ID from the chat box, and queries, if any, you can directly ask the ma'am. So we end the Kayaprabodhini webinar series, episode 7, and we'll meet soon with another episode of the Kayaprabodhini webinar series. Thank you, ma'am, and thank you, one and all.